I'm here with Zach, and we're just going to go over some cases with some ultrasound images to show you how we would go about filling in the form and talking about some of the clinical implications of the ultrasound findings that you guys have been coming across. So for the first case, we had an elderly gentleman admitted to the medicine wards with neurologic deficits concerning for stroke. Communication with the patient was limited. There were a few crackles on exam, and he was found to be hypoxic instead of receiving 2 to 3 liters of oxygen via nasal cannula. And so the indication for this ultrasound would be evaluation of hypoxia. So we can start with that on the form. Nice. The way that this form is set up is that we first are looking at the IVC resting diameter. There's instructions in the Canvas course on how to obtain that and measure it, but we measured it for this patient, and as you can see in the corner, it's 2.09. So we can do between 1.5 and 2.4 centimeters.
And in this particular example, we don't have a video showing whether there was or wasn't collapsibility, but despite the fact that the IVC was a little bit dilated, its collapsibility was well over 50%. So assessing the IVC, sometimes it's important to get the full diameter, but it's also important to measure how much it's collapsing. And in this particular example, we also don't have the formal calculation of its minimum diameter and its maximum diameter to get a formal measurement of the IVC-CI or the IVC collapsibility index, but that's the most formal way to calculate how much it's collapsing and helps predict whether someone would or wouldn't be responsive to fluids in the case of sepsis. But here, in the case of someone who's hypoxic, having an IVC with even moderate collapsibility suggests that they at least don't have significantly elevated CVP.
So I'm just going to say could not calculate.
So for could not calculate in this particular image is because those images weren't saved with this particular image set.
Cool. And then the second section of the form goes into the pulmonary ultrasound findings, which are here. We can play some of the videos for you. They're labeled in the upper left-hand corner. You can see in R1, it looks like an A-line pattern. I don't see any B lines. And you could go through and do that for all of the lung fields. So R2 also looks maybe like 1 B line.
It's a little hard to see on some of these because they're so small, but looking at it, you'll see some artifacts coming from this pleural line. They have these kind of shadows, but that black shadow there is not consistent with a B line. It's a different type of pleural artifact. So in this case, even though the machine appears to be calculating a B line, it's important to verify where that line occurs sort of at the end of the video clip. And it seems to be counting what I would say is not actually a B line. Those B lines should arise from the pleura, and they should extend all the way through the ultrasound field. And generally speaking, they're going to be white in color. And the pleura also needs to be moving at the place. So here we have moving intact pleura, but it's not actually a B line that's being highlighted. So in this case, it's a normal A line pattern, but again, 1 to 2 B lines can be considered normal. So even if in this case you were to select the 1 to 2 B lines, it wouldn't necessarily change your impression because this would still be a normal finding at the R2 site.
Okay, good to know. Where's my cursor? So I'm gonna just say A lines only, and I mean I don't think we really need to go through all of them because they look very similar. This looks like
yeah. So again, R3 also nice.
Oops. onto the left lung. I'll just play these really quickly, but it all looks like A lines.
Yeah, so in summary for this patient's lungs, there's bilateral findings of diffuse A lines, so argues against any type of pulmonary edema or infection as a cause for hypoxia.
And we did not, at least on these images, appreciate any pleural effusion or consolidation.
So you can just leave those
yeah.
blank.
And so the last part of the form goes into the cardiac images and their interpretation. Just as we did in the course, they kind of started out with parasternal long axis view here. We went on, or do you want to start with an estimate of left ventricular function, or do you want to go with something PSS?
We do either one. Yeah, so I mean, starting with the parasternal long axis, that's the most common, first, and easiest view to obtain. I can tell from the ultrasounds that have been submitted by everybody that they're getting good parasternal long axis views. And in this particular view, we can look to help us get the ejection fraction at the movement of that anterior leaflet of the mitral valve. In this particular case, it seems like it's maybe getting about 50% of the way towards that interventricular septum, at least visually. I don't know if we formally calculated an EPSS in this particular example, but there's a suggestion here with the movement of that anterior leaflet that there's not quite the normal amount of movement there, so suggesting that there's some reduction in the ejection fraction on first pass here.
And I think they did calculate it.
Yeah, so then here on sort of the more formal calculation, what you want to do is set that M mode, and many of you have been doing this between that anterior leaflet down towards about the bottom third of it, making sure that to the best of your ability, you're running as close to 90 degrees through that interventricular septum, and then again, measuring more formally how close it gets. And anything over 1 centimeter is generally considered elevated and oftentimes does correlate with low ejection fraction. In this case, the formal calculation of the EPSS was 1.7 centimeters, so highly suggestive of reduced ejection fraction.
Would you say mild to moderate or severe?
I would take this, and then I'd also look at my parasternal short axis, and then we'll kind of make that determination.
So this is getting like an apical 4 chamber.
Apical 4 chamber, yeah. So the apical 4 chamber, oftentimes the most difficult view to obtain, can require some patience, but is primarily useful in sort of assessing the left ventricular and right ventricle next to each other, and helping to see, is there a size discrepancy that we wouldn't expect. And in this case, the right ventricle appears to be appropriately smaller than the left ventricle. Left ventricle does look a little bit large, but sometimes that's hard to make a determination in this view unless it's formally measured. And the right ventricle does seem to be moving generally pretty well. So the apical 4 chamber is usually the best way to sort of estimate the right ventricular size, and I agree, it looks like about half to a third the size of the RV, so very LV, excuse me.
Cool. So I filled it out in the form.
It should have a parasternal short somewhere in there.
Yeah, it's more apical 4 chamber. This is the best parasternal short.
So here's the parasternal short, and again, like we kind of have talked about, you can see on that, at least on the image here on the right side of that image, there's a little bit of rib shadowing of the parasternal short, or of that particular side. We can see on the left there's a nice papillary muscle. We don't get the full circle of the left ventricle, but in this view, we should see approximately 50% collapse of the left ventricle with each systole. And in this particular case, I'm seeing very little. So I think in combination with an EPSS that was in that more than 1 centimeter category, plus this view showing that there's very little movement of the left ventricle, probably this would qualify for severe reduction in EF on a point of care ultrasound standpoint. So pretty significantly, probably less than 20%, maybe even down closer to 15%, but certainly would qualify for severe LV dysfunction. And there's some suggestion from putting together what you see on the peristernal long axis with a little bit of thinning of the interventricular septum, that this person probably does have some degree of coronary artery disease, and maybe had an MI. We don't have an EKG to help correlate that, but might be seen.
Well, and then would you say, I mean, I don't think the septum looks flat to me, but
No, I don't think so. It looks to me like during systole, it's maintaining a nice circular structure. So the right ventricle seems to like it has a fairly low pressure.
okay. And then there's no pericardial effusion present on any of the images that we saw.
Any pericardial effusion.
And that would be it for this patient case. Cool. I'm just gonna refresh the form.
Yeah.
So for our second case, we have a young man with HIV off ART admitted with encephalopathy and sepsis. His lumbar puncture was negative for cryptococcal meningitis, and his TB diagnostics are pending. On the third day of his admission, he had worsening sepsis physiology and increasing hypoxic respiratory failure with tachypnea. His lungs were clear on exam, and he had no lower extremity edema. His abdominal exam had no distension or peritoneal signs. And so the primary indication for this patient would probably be either hypoxia or sepsis evaluation.
Yeah, sometimes it's hard to know what your primary indication was. Sometimes I think about, well, what would I do with the information? So it sounds like we're kind of wondering, should we give the patient fluids? Maybe their blood pressures are getting a little bit worse. I'm wondering, maybe they need diuretics for increasing hypoxia, maybe it's heart failure. So I think either way, you could say this is for sepsis or this is for hypoxia. Sometimes it depends a little bit on your clinical impression at the bedside, knowing this case. And many of you might remember this case that we did in October of last year, because we did it while we were there. We were doing it primarily at that time for sepsis evaluation. So we can kind of see what we find as we go through it.
So starting again with the IVC ultrasound, there were no measurements done, but.
Yeah, and I think that's an important point that Eesha brings up, that sometimes, you're doing this quickly, and it is, from an academic standpoint, it's good to do measurements so you know exactly what you're looking at. But sometimes just looking at it visually, we can see here that there is an IVC. There's a little bit of shadowing, but it looks to me like towards the end of that video clip, the IVC collapses completely with the respiration. You can even just tell, look at how quickly the patient is breathing. His respiratory rate is going very fast, and his IVC is collapsing with each of those little respirations. It's a very tiny IVC. So I think we can say that there's complete collapsibility of that IVC. And I guess from a full technical standpoint, because we didn't formally measure it, we probably would say here that we didn't calculate the resting diameter of this IVC, which is okay.
Oh, I was just gonna estimate it at less than 0.5.
Yeah, so that's possible. I think that if you're going to do this formally, you'd want to pause and measure it. It would be sort of like could not measure if for something happened with the machine. So I think since we don't have the image, I think it's okay to say could not measure, but ultimately sometimes your clinical impression is best. So in this one, it's collapsing completely, and so a completely collapsing IVC tells you that the patient has a very low central venous pressure, and certainly if they have sepsis, warrant some additional fluids, regardless of what the formal measurement might be. So sometimes, from a clinical standpoint, completely collapsing, regardless of what the resting diameter is, doesn't necessarily change what you do. So from a very formal standpoint, this would be the way to fill. If this is the only image available, we would just say collapsing completely.
Okay. So moving on to the pulmonary ultrasound. This is where it gets kind of interesting. So looking at R1, we see a lot of B lines kind of diffusely. let's say maybe 3 or more.
Yeah, and you can see that machine is picking up quite a few of them. And in this case, there definitely appear to be B lines, where present, they seem to be eradicating that A line, which appears, and then the B lines kind of cover it up as they start to come into view. And the B lines in this particular R1 example are almost fused together. It's almost like multiple B lines, and they all appear to be arising from the pleura. They're going through the entire ultrasound image, and the pleura is moving with each respiration. So those qualify as definite B lines, and I'd say certainly more than 3 in that particular example.
And then I would say similar here. I don't know if the bottom right corner counts as like abnormal pleura. Versus shadowing.
Yeah, I think that probably on the sort of right-hand side of that image, there's probably a little bit of rib shadow. So when we got this picture, we must have been on that. The inferior edge of that rib must have been just underneath the ultrasound probe. But yeah, again, just tons of B lines. And again, pleura is moving, going through the whole ultrasound field. And so meeting all the criteria that we need to have to be a formal B
Yeah, I'd say the same probably for
Yeah.
R3.
And if you look there at R3, at the very end of the image, that it almost looks like the pleura. I can't quite tell, but as long as the ultrasound machine was being held still and wasn't slid on the patient's body, you get to see a little bit of what's a pleural defect with one of their deep breaths. And so there's also some irregularity to the pleural line there visible as well.
Should I document that?
No. I think that the abnormal pleural line we may see some examples of that. Oftentimes the entire pleural line will look sort of chewed up and broken apart. It looks pretty abnormal. But most of R3 there, for most of its image, looks pretty intact with B lines that appear to be arising all the way.
And then this is for the left lung. I think similar pattern throughout.
Yeah, and you can see some normal A lines there in the R3 category also then being covered up and kind of erased by those B lines. So that's a very classic picture for focal areas of B lines and inflammation. And then sort of in that R1 category is another example of where you see how the pleural line there appears to be pretty discontinuous. There's that area on the right-hand upper side. Yep, on the sort of upper right-hand side of that image, there's a little bit of the pleural that looks kind of discontinuous. So here's should be a nice straight pleural line. All of a sudden you get to this thing, which looks a little bit weird, what's going on there. So that's what we call it's kind of like a little pleural irregularity. And then underneath that, you see what looks like B lines arising from it. And technically, those don't qualify as B lines because they're not arising from an intact pleura. These ones over here, they would qualify as B lines. So this particular image R1 is a little bit difficult to know what to do with. So I think that if you have enough experience, you might feel comfortable saying, well, this part of the intact pleura seems to have enough B lines. It's certainly more than 3, but if you're not quite sure, this could be an abnormal pleural line there for R1 or L1, excuse me, because this irregularity there, maybe you don't know what to do with. Otherwise, if you do feel comfortable saying that, yeah, I see that there are enough abnormal B lines coming from what appears to be a moving and intact pleural line, there certainly does appear to be more than 3. This is one of the challenges with interpreting ultrasound images. Sometimes you see things you don't know exactly what to do with. But very specifically, that image there is called a subpleural consolidation. It's consistent with sort of a infectious process, usually at the edges of the pleura. And so an additional diagnostic clue, but in terms of, a sepsis evaluation, we had from the IVC, a completely collapsing IVC and now bilateral B lines throughout both lungs with some pleural irregularity.
Okay. And then would you call that a consolidation?
So consolidation refers to sort of a consolidation within the lung, and we don't see that here.
Okay. So I'd still leave that field blank and then I would say beeline.
Yeah,
pattern,
beeline
likely.
pattern for this one, because there's bilateral diffuse B lines. There's no areas where there's a lot of normal A lines and then some B lines. It's diffuse throughout both lungs.
Okay, so for the cardiac ultrasound on this patient, starting again with the parasternal long, that looks pretty hyperdynamic.
Yeah, and the key to these ultrasounds is trying to hold your ultrasound probe still, but this patient's obviously breathing pretty quickly, and so you kind of sometimes have to look for the best potential image. And if you look carefully and with each, so you'll see that the valve there of the mitral valve appears to be sort of whapping directly against the interventricular septum, and there's near complete collapse in that parasternal long axis image there.
And I don't think we obtained the formal EPSS measurement.
Yeah, and I think, you know, the struggle with trying to obtain it from that particular image is you kind of need to be able to see the whole thing clearly throughout at least multiple cardiac cycles to be able to calculate an EPSS. So even if you did try with that particular image, you might not be able to do it.
So I would say,
Yeah, so for the EPSS could not calculate, you know, we didn't, you know, that doesn't mean you didn't do a good ultrasound, just means that you didn't have a good enough image for obtaining that measurement.
okay. Yeah, I remember this patient was hard to.
So then here's our parasternal short axis. So the heart again is kind of swinging in and out. You can see actually some lung up there in the upper right-hand corner as the heart kind of moves into view. And so, you know, it's difficult to really say much about this particular parasternal short axis view, but in combination with what we know from that parasternal long axis, we can see that there is quite a bit of movement, quite a bit of collapse. We don't quite see the you know, that the walls touching each other, but they're pretty close during at least one cardiac cycle. I feel like I could see a pretty good circle forming there, and it almost completely collapses there.
So just reinforces our assessment of it being hyperdynamic.
Yeah, it looks like pretty hyperdynamic.
And
Definitely not a
no
low EF.
flattening either.
Yeah, it looks like it kind of retains that nice circular shape there on the interventricular septum. Let's see.
I think we tried to get an apical four chamber. But
Maybe it's too difficult. You can from the subxiphoid image still get a good sense oftentimes of the ventricular size next to each other. And again, this looks like there's a lot of good movement of the heart in general. That right ventricle looks like I would say is, you know, falling into that half to a third the size of the LV. So very normal. No signs of right ventricular pressure over the
or effusion.
Yeah, I'm not seeing any pericardial effusion either.
Okay, so that would be it for this patient. Yes. Just refreshing the form. And then our third and final case, case C, is a young gentleman admitted with severe sepsis and encephalopathy. He had severe hypotension with tachycardia, but was not hypoxic. He has a limited history. A friend told the treating physician that he was HIV positive, but confirmatory testing was negative.
Again,
and so the indication.
Probably looking for sepsis evaluation again here.
Starting with the IVC ultrasound. Looks very collapsed.
Yeah, so nice clear pictures there. We've got an IVC that's open as they breathe in, and then as they breathe down, collapsing. So a small, completely collapsing IVC. I don't know if we formally measured this one or if we just got the general impression.
I don't think we formally measured it.
So then we would say resting down could not measure. IV, you know, we didn't formally calculate that, but the was completely collapsing. And it, you know, visually looking at it, you know, inferior vena cava resting diameter, it's certainly less than 1.5 centimeters. I think though, without saving an image, formally documenting that for this research form, you probably would just say could not measure.
Okay, even though the protocol like has instructions based on the IVC diameter.
Yeah, I think that we may want to think about, in the cases where we're really going to be making the decision off the ultrasound, we probably do want to formally measure with at least one static measurement where we draw it across the center of the IVC there and formally document its measurement.
So try to do that whenever you can, I guess.
Yeah, and most of the time when I've been reviewing the ultrasounds that have been uploaded, people have been very good about measuring actually both the resting diameter and a collapsing diameter, and then formally upling, and then at least giving themselves the opportunity to formally calculate the cable index. So you guys are doing very well with that. And so we're being sort of technical and picky with ourselves going through this form since we have somewhat limited images for these examples.
Nice. And then for the pulmonary ultrasound for this patient, we didn't include the images, but it was A lines throughout. Lastly, for the cardiac ultrasound, I wasn't really sure what view this was. It looks like a parasternal lung, but
Yeah, so here's a confusing parasternal long axis picture. The mitral valve is here. This is the left ventricle. Here's the right ventricle over here, and here's the aortic outflow tract. You can also remember to center yourself on that descending aorta. And as you can see, as the heart's moving, there is this hypoechoic space that's forming here along the posterior wall of the left ventricle. And so from this particular image, we can see that there's a lot of hyperdynamic function of the LV. And we also get a sense that there's probably a pericardial effusion there that's at least small to moderate in size. And so we'll want to get some additional information about that pericardial effusion as we get additional pictures.
I think this is just kind of showing the same thing.
Yeah, so here's a subxiphoid image. So again, we're kind of have our right ventricle over here. Here's our left ventricle. And from this particular image, we can see that that pericardial effusion is small to moderate, kind of going around the whole heart there, so that there's a circumferential, small to moderate sized pericardial effusion.
Oh, not a pleural effusion.
We have our parasternal, here's our parasternal short axis. So again, nice tiny little circles, almost like the ventricle's getting a little squished there. But yeah, or a little technically, this image is a little high. You can see kind of the fish mouth of the mitral valve, and ideally we would want to be down a little lower so that we see the papillary muscles. So a little bit high for the perfect assessment of the LV, but we know in combination with this particular picture and the parasternal long axis that we've got a completely collapsing hyperdynamic LV here.
And so kind of just putting that all together. We didn't really go over the lungs, but looks like a hyperdynamic left ventricle.
I don't think we
calculate that.
calculated it.
The right ventricle size looked normal to me.
And I think if we go back to usually our parasternal long axis, or I think if we go back to that parasternal, apical forechamber, one image back. There we go. So from our apical forechamber view, there's a little bit of, we don't quite get the right ventricle lying nicely next to the left ventricle for the whole time, but for the brief moment of time where we do see the wall of the right ventricle moving next to the left ventricle, we do see that it looks like, to me, I'd still say a third to a half the size of the LV. It does not look to me like there's any right ventricular view.
And no septal flat.
No septal flattening.
And yes, there was.
So then we do have a pericardial effusion. So now the next questions we want to ask ourselves is, are we seeing anything about this? And so small, not circumferential. So these would be sometimes these small amount of pericardial effusions that are occurring that don't appear to go all the way around the ventricle or around both ventricles. So in this case, there's at least a moderate sized pericardial effusion because it seems to be going around the whole heart there.
That's visible on this.
And then looking, the next question is there any hemodynamic changes? And I know we talked a little bit about this in the course, and this particular patient has a good example of the early changes of hemodynamic compromise in that you can see here during diastole, the right atrium appears to be sort of moving inward, indicating the pressure of that pericardial effusion is actually starting to have some degree of hemodynamic compromise. And so clinically, many patients would be considered for pericardial or pericardiocentesis in these scenarios, which is of course limited in many places. And so certainly before doing a pericardiocentesis in the patient with a completely collapsing IVC, a pericardial effusion starting to show some degree of collapse of the right ventricle, definitely a strong indication for giving more fluids. And so most of the time, the answer to will there be a pericardiocentesis will be no, because oftentimes it's difficult to get that done, but it has been arranged before. And so depending on your degree of concern, but in this case, we'd probably say that it's, patient is under resuscitated, give more fluids. We've got an A-line pattern. We've got some hemodynamic changes. And exactly what the pericardial effusion is from is going to require some clinical decision-making going through the history. We do know the cryptococcal antigen was negative and HIV test was negative, but could it be tuberculous? Could it be viral? Could it be hemorrhagic? So whatever the history might be to help you kind of figure out what could be causing that pericardial effusion comes next. But from what do we do about the low blood pressures and this finding of a little bit of early changes of hemodynamic compromise, ultrasound helps you feel very good about giving more fluids.
Okay, well, that was our last case, but thanks a lot, Zach. That's very helpful. And we'll soon have a follow-up video kind of talking a little bit more about how to make clinical decisions based off of the ultrasound findings that you're filling out very well in these forms. Thank you, everybody.